my name is Barbara Weber. I am a current student at Midwestern State University, and my capstone project is titled Improving Acute Pain Management in Adult ER Trauma Patients Using Non-Pharmacologic Interventions. By the end of this presentation, the audience will be able to identify current challenges and gaps in ER pain management, recognize evidence-based non-pharmacologic methods that can be used to manage pain effectively, describe the implementation plan for the Comfort Bundle and how to integrate it into their current nursing practice, and lastly, how to advocate for safe, holistic, and effective pain alternatives in trauma care. The reason why I chose my topic is because many people suffer from undertreated pain. Studies show approximately 80% of patients suffer from inadequate pain management. Unmanaged pain has detrimental consequences such as psychological effects like depression, anxiety, sleep disturbances, and cognitive impairment. It also leads to extended hospital stays, increased healthcare costs, resulting in financial strain on the patient and their family. It also lowers quality of life and makes it difficult to perform activities of daily living. Pain is a complex subjective experience influenced by physical, emotional, and cultural factors. This is why an individualized approach must be used when creating care plans for patients suffering from acute pain. In 1996, the American Pain Society introduced pain as the fifth vital sign and to reduce underassessment. Surgical and invasive pain interventions pose many risks such as infection, anesthesia complications, bleeding, nerve damage, scarring, and disfiguration. Pharmacologic pain interventions such as medications provide a non-invasive way to manage pain, which aids sleep, comfort, and function. Opioids are commonly used in ERs to treat acute pain despite the risk like respiratory depression, opioid use disorder, and overdose. Studies show that over 50% of patients will be discharged with a narcotics prescription, and emergency departments prescribe 12% of all opioids. In 2023 to 2024, the CDC reported over 137,000 opioid-related deaths in the U.S. Non-pharmacologic pain control methods offer a safer alternative to pain control. Comparing pharmacologic versus non-pharmacologic outcomes reveals gaps. There haven't been many studies conducted in emergency departments that compare the outcomes and the effectiveness, thus leading to some healthcare providers not feeling confident to implement non-pharmacologic pain interventions. The goal of this capstone is to promote safe, evidence-based, holistic ER pain practices. My problem statement is, in adult ER trauma patients, how does the use of non-pharmacologic pain interventions compared to opioid administration alone affect patient-reported pain levels? I conducted an extensive literature review from peer-reviewed nursing journals, and some of the highlights I found talked about how in 2019 the Joint Commission revised pain assessment management standards and required the development of non-pharmacologic pain treatment or a combination of approaches to be used by all facilities. And the reason being is due to the opioid crisis that many believe was caused by pharmaceutical firms aggressively marketing their pill. A very popular example is Purdue Pharma pushing Oxycontin for physicians to distribute without fully researching the deadly effects. Another article talks about how multimodal analgesia decrease opioid use in adult trauma patients. Multimodal analgesia, or MMA, is when you use at least two medications with different pharmacologic actions to provide pain relief, and it has been shown to be just as effective in managing pain as using opioids alone. MMA commonly consists of NSAIDs, acetaminophen, muscle relaxants, and local analgesics. And usually it's used in conjunction with opioids. In the article, they did a study in 2018 on patients using MMA and compared it to a control group of patients admitted in 2016 who did not receive the MMA interventions. The studies showed that MMA was just as effective in managing their pain, and there wasn't an increased incidence of acute kidney injury. Studies also show how pain is exacerbated by anxiety, and that is why the use of deep pressure therapy, such as weighted blankets, is now being used to treat injured trauma patients. It works by stimulating the vagus nerves, which helps reduce severity of pain perception. Also, music therapy has been shown to have promising results. For treating pain, it is a distraction technique that stimulates the secretion of endorphins and other mood-enhancing neurotransmitters. It works as an emotional regulator in managing stress and anxiety. It's often used in combination with other analgesia methods. It ends up relaxing patients, which results in decreased heart rate and blood pressure, thus leading to decreased perceived pain intensity. Other studies have shown how opioid-naive patients discharged from the ED with opioid prescriptions are more likely to transition to persistent or high-risk opioid use. And also research has found no significant pain relief advantage of opioids over non-opioid options, such as acetaminophen or naproxen. My proposal plan description is called the Comfort Bundle. It's an implementation of a bundle approach using evidence-based practice, non-pharmacologic interventions. This includes hot-cold therapy, repositioning, meditation, music, therapeutic communication, deep breathing techniques, and distraction techniques. And patients will be split up into two different groups. There will be a group A, which will receive opioid-based pain management, while group B will receive the Comfort Bundle, in addition to minimal or no opioid administration, depending on clinical judgment and patient response. We will be using a sample size of approximately 60 adult trauma patients experiencing moderate to severe acute pain. This will be conducted over a 3-month period in a level 1 trauma emergency department. Pain ratings will be assessed using standardized pain assessment tools documented at admission, throughout their stay, and at discharge. At the end of the trial, we will analyze patient-reported pain levels and satisfaction to evaluate the impact of the Comfort Bundle. The goal of this proposal is to demonstrate how low-risk, non-pharmacologic pain interventions can significantly improve pain control and patient satisfaction, while also reducing reliance on opioids in emergency care settings. The key stakeholders for this project include the nurses, patients and families, emergency physicians, clinical educators, and hospital administration. Nurses play a vital role because they will be the one implementing and documenting the interventions. Emergency physicians support the plan by prescribing appropriate MMA interventions that align with the patient's condition and pain tolerance. Hospital administration is impacted by patient satisfaction scores, healthcare outcomes, and the potential to reduce costs. Clinical educators are responsible for training, coaching, and auditing staff compliance with the Comfort Bundle interventions. Patients and their family play an active role by participating in their care, having the willingness to learn and openly communicate with staff. Their feedback is very important and will help us improve these interventions and tailor them more effectively. Also, it'll help patients to feel more in control. Whenever patients are in hospitals and experiencing pain, they often feel like they have a lack of control in their life. Some limitations and barriers we might face is the short ER stays. It may not give us enough time to evaluate the long-term effects of the comfort bundle. Also, time constraints. The ER is very fast-paced, high stress, with high turnover rates. There's also the environmental factors like noise and crowding. There may also be issues with staff who are resistant to change. They may not want to participate in the comfort bundle, may not care, and may be lazy, various reasons. Also, limited staff training time and having access to a private space to provide this training. And also pain perception variability. Every patient experiences and reports pain differently. My implementation plan is as follows. First, it'll start with education. All emergency department staff is required to complete required education session on the risk associated with opioid use, such as respiratory depression, prolonged hospital stays, dependency, addiction. Nurses will also have the option to complete a continuing education course of their choice from approved sources, such as the Texas Opioid Training Initiative continuing education programs, trauma-informed care continuing education, implicit bias training, or motivational interviewing for healthcare professionals. The goal of the education courses is to promote empathy, accurate pain assessment, and reduce bias. Staff will also be trained on how to develop individualized care plans that incorporate both pharmacologic and non-pharmacologic interventions. Training will emphasize the benefits of multimodal analgesia and evidence-based non-pharmacologic pain interventions. A comfort bundle checklist will be used to guide nurses in selecting and documenting interventions for adult trauma patients presenting with moderate to severe pain in the emergency department. Nurses will also use standardized pain assessment tools such as the numeric rating scale, visual analog scale, the Wong-Baker Faces pain rating scale, the brief pain inventory, and the pain impact questionnaire. These assessment tools will help nurses better assess, document findings, and create appropriate interventions to improve pain management and patient outcomes. Staff will also participate in weekly one-on-one coaching sessions with clinical educators to ensure fidelity to the project and proper documentation practices are being met. Weekly audits will be conducted by clinical educators to review the pain assessment scores, intervention usage, and whether pharmacologic therapies were appropriately delayed or given. Any staff having difficulty following protocol will receive additional support and reinforcement training. To evaluate the outcomes, I will use both quantitative and qualitative data to evaluate the effectiveness of the comfort bundle proposal plan. Quantitative outcomes include patient-reported pain scores using standardized assessment tools, timing of pain relief, and opioid administration rates collected from the electronic health record before and after implementation of the comfort bundle. Qualitative data will be gathered through anonymous staff surveys that evaluate confidence and perceived effectiveness of using the non-pharmacologic interventions. Survey will be in the Likert scale format and include 2 open-ended questions at the end. Clinical educators will develop the survey using a HIPAA-compliant software called VoxGo. Patients will also be offered satisfaction surveys that follow a similar format. The survey will measure their perceived pain relief, involvement in pain management, satisfaction with their nursing care, and their overall satisfaction of their ER stay. Their feedback will provide insight into perceived benefits, challenges, and areas for improvement. The data will be compared to the previous 3 to 6 months before the Comfort Bundle was implemented, focusing on the average pain scores, opioid usage, and patient satisfaction scores. The project effectiveness will be measured by decreased patient pain scores, reduction in opioid use, improved patient satisfaction scores, and positive staff engagement. To share my outcomes on several different scales, I will be doing a couple different things. So at the unit level, results will be presented to the emergency department staff during huddles or team meetings through posters, handouts, and short presentations. At the hospital level, the project will be presented to nursing leadership, the education department, and the opioid stewardship committee. The education department and I can create this project into a continuing education course that is recognized on a nationwide level by the Texas Board of Nursing, and this course can go towards the 20 contact hours of continuing nursing education required by the Texas Board of Nursing to renew licenses every 2 years. To share my outcomes on a broader scale within the professional community, I plan to submit an abstract for publication in a peer-reviewed journal such as the Journal of Emergency Nursing. Also present this information at conferences hosted by the Emergency Nurses Association. I can also share my findings during Nurse Professional Development Week, which is celebrated annually around the third week of September. To ensure public access, I will also upload the final abstract and summary to nursing research databases such as SONAL and PubMed so that other professionals can learn and apply these evidence-based findings in emergency care settings. The goal is to positively influence how pain management practices are delivered on a national scale. As part of this project, I interviewed an expert, Stacy Alexander, MSN, ACNP-AG. She's a nurse practitioner with over a decade of nursing experience working in the emergency department. She has cared for many trauma patients experiencing acute pain. She shared some of the non-opioid strategies that they implement on her unit, such as making the patients feel more comfortable, repositioning ice packs, early mobility. She's talked about how nurses must feel confident and have education on how to deliver non-pharmacologic interventions. Some barriers to implementation she's witnessed includes time constraints, staff shortages, limited supplies, or missing activity orders from providers. One of the most powerful shifts she has seen during her time working with trauma patients is how providers now spend more time with patients and help them set realistic goals in maintaining a bearable pain level rather than trying to eliminate pain completely, aiming for a 0 out of 10 score, pushing morphine every 2 hours. She's seen more of a multimodal regimen approach. Ms. Alexander emphasized how nurses must feel confident in their skills and how they are key advocates in promoting non-pharmacologic interventions. Her insights reinforce how important it is to empower bedside nurses to push for individualized care plans and multimodal pain strategies. Her interview added valuable real-world context to my proposal and highlighted the important role nurses play in advocating for safer, more holistic pain management and emergency trauma care. In conclusion, we have learned how many patients suffer from undertreated and unmanaged pain and the detrimental effects it has on one's quality of life. Opioid use and surgical interventions for pain management pose significant risk to patient safety and long-term health. That is why we must push for the use of non-pharmacologic pain interventions, such as the Comfort Bundle approach, to be used in emergency departments to treat acute pain and trauma patients. By prioritizing safer, patient-centered approaches to pain management, we can reduce harm, improve outcomes, and ultimately transform the standard of care. Thank you for watching my capstone presentation.